Hello, I'm Bill Middleton. I'm a professor of radiology at the Mallinckrodt Institute of Radiology in St. Louis at Washington University School of Medicine. My lecture is on sonography of liver masses. So the topic of this lecture is sonography of liver masses. There are 6 lesions that we're going to focus on during this lecture, and you can see the list there. We're going to start with cysts. Cysts are the most common liver mass, and unlike in the kidney, where sometimes they can be a little bit tougher to detect and characterize, in the liver, cysts are generally very easy to detect and are fairly easy to characterize as well. They usually display the classic sonographic findings of cysts, that they're anechoic, they have posterior acoustic enhancement, and they have a strong reflection from the back wall. Now, puckering and septations or partial septations along the wall of hepatic cysts are not uncommon and shouldn't concern you too much. So this is a typical appearance of a liver cyst: anechoic, increased through transmission, strong reflection from the back wall. Here's a small liver cyst that was scanned after the patient had an indeterminate lesion seen on CT. You can see the cyst here, and even though the cyst is significantly less than a centimeter in size, it still has strong back wall and a little bit of increased through transmission. Now this case raises an interesting dilemma. What do you do with cancer patients who have small indeterminate lesions seen on CT? Is sonography helpful in those situations? And there was a nice study that was published in the Journal of Ultrasound in Medicine in 2003 that looked at 76 patients who had 124 lesions, all of which were less than 15 millimeters. And the mean size of these lesions was 7.5 millimeters, so less than a centimeter in size, mean range. And they had either follow-up histology and or follow-up imaging in all of these patients for a mean of 17 months. And what they found was, if you looked at all of the lesions that were being evaluated, sonography could detect slightly less than half of them, 48%. If you subcategorized those into the lesions that had a CT readily available for reference, then the detection rate increased to 66%. But if the CT wasn't available to compare with the ultrasound, then the detection rate was only 32%. And this was a statistically significant difference. Then if you looked at lesion size, if the lesion was bigger than 5 millimeters, the detection rate was 67%. But if the lesion was less than 5 millimeters, then the detection rate was only 19%. But if you look just at the patients who had lesions that were bigger than 5 millimeters and the CT scan was available for direct comparison, then the detection rate was 83%. And these are probably the types of patients that you're going to see most often. And hopefully, when you do these exams, you will have the CT available for comparison. Then of the 60 lesions that were actually identified and detected sonographically, these are the results of the lesion characterization. If you look at this row here, of all lesions that were characterized, sonography was correct in 93%. It was correct in 95% of the cysts, in 88% of the solid metastases, and in 100% of the hemangiomas. So the bottom line from this study is that small indeterminate lesions seen on CT in cancer patients should undergo sonography for further lesion characterization. And here's an example of a patient with breast cancer who is status post partial mastectomy, who presented with chest wall pain and lower extremity swelling. And on her CT scan on this axial and coronal reconstruction, you can see on both images a tiny liver lesion adjacent to the right kidney. Well, on sonography, if you look closely, you can see that this corresponds to a very small cyst. And notice that that cyst is anechoic and still has increased through transmission, despite the size that it's probably slightly less than 5 millimeters in size. Now, there are things that can mimic simple cysts, and vascular lesions are among the most common. This is an example of a liver transplant patient who had a simple appearing cyst on grayscale, but it contained swirling blood flow on color Doppler. And this was a post-biopsy pseudoaneurysm that was subsequently confirmed with angiography. But in addition to pseudoaneurysms, routine aneurysms can simulate cysts, as can arteriovenous malformations. And one particular tumor, lymphoma, is notorious for being extremely hypoechoic, and rarely it can be anechoic and simulate cysts in the liver and elsewhere in the body. Now, what about cysts that aren't simple, that appear complex? The differential for that includes hemorrhage into a cyst or hematoma, infection in a cyst or abscess, metastases, echinococcal disease, biomas, and biliary cystic tumors. And I want to just focus for a minute on infection and talk about abscesses. So abscesses can have a fairly typical sonographic appearance, and that is a complex fluid collection, often with multiple loculations. But it's important to realize that abscesses can also appear solid and can simulate neoplasms. In the right clinical setting, a solid lesion should be considered a possible abscess until proven otherwise. And small abscesses, microabscesses, in particular those caused by candidiasis, can have a targetoid appearance, as we see here, or can have an appearance that's called the wheel in a wheel appearance, where you see multiple layers of varying echogenicity. Now, if you're dealing with a complex cyst, the way you confirm the diagnosis is generally with clinical history and laboratory studies. That will often allow you to determine what it is, or at least to determine what the management should be. Doppler is obviously helpful to see if there's internal blood flow, or if it's a primary vascular lesion to begin with. In many cases, a follow-up exam in a few weeks will clarify the situation, and if necessary, ultrasound-guided needle aspiration can always be performed. Okay, now I want to move on to the next lesion, which is hepatic hemangiomas. Hemangiomas are solid lesions with multiple tiny blood-filled endothelial-lined spaces. They're like sponges in the liver that are filled with blood. It's the most common solid liver lesion that you'll encounter. It's present in at least 7% of the population, more frequently in women than men. They're usually less than 3 centimeters in size, and although most are solitary, up to 10% will occur in multiple locations. The sonographic appearance of hepatic hemangioma is typically that of a solid lesion that's homogeneous and uniformly echogenic, sometimes with, sometimes without slight scalloping of the margin. A reverse target appearance, that is a lesion that has a hyperechoic rim, is also very typical of hemangiomas, but seen less often. Larger lesions are often atypical. Through transmission does occur, but it is uncommon. The majority of hemangiomas are stable over time, but 20% will change in some way, and those that change over time usually will go from hyperechoic to hypoechoic. And rarely they can change, typically in that direction from hyper to hypo, over a short period of time during the course of a single examination. And although these are lesions that are filled with blood, they have very slow blood flow, so you usually don't see much flow, if any, on Doppler. So here's a typical hemangioma, homogeneous, hyperechoic, well-defined lesion in the liver. On Doppler, they have very little, if any, detectable blood flow. This is the reverse target appearance, where you see a hyperechoic rim surrounding an isoechoic central component. This is a case that was loaned to me from a former fellow of mine. And you can see on the initial examination, there's a fairly typical homogeneous hyperechoic liver lesion. 9 months later, it had converted from hyperechoic to hypoechoic. Here's another lesion that comes from another former Mallinckrodt resident, where during the course of the exam, a lesion typical of a hemangioma was seen initially here, and later in the examination, it had changed to the point where it was slightly heterogeneous but predominantly hypoechoic. And this occurred over a matter of several minutes. Now, atypical hemangiomas do occur, and they have a variety of appearances. One of the most common is a hypoechoic hemangioma, and that tends to occur in patients that have increased liver parenchymal echogenicity secondary to fatty infiltration, as we see in these two cases. Large hemangiomas often are atypical, and these are two examples of heterogeneous, nonspecific liver lesions that did turn out to be hemangiomas. And then finally, hemangiomas can occasionally be targetoid. Now, fortunately, this is very rare. The majority of target lesions that are encountered on sonography, as we'll hear about later, are malignant, but very rarely a hemangioma can have a target appearance, as in these two cases. Target appearance is a lesion that has a hypoechoic rim. So, how do you deal with hemangiomas? Well, one of my former fellows did a study that was published in Radiology in 2000, where he looked at 383 patients that had the word hemangioma in the ultrasound report. And of those, he eliminated 16 that on review were atypical, 95 that occurred in patients who were high risk for malignancy, and 59 who had insufficient follow-up, so this group. And that left him with 213 patients who were at low risk for malignancy and who had typical hemangiomas on sonography. Of those 213, 121 had imaging and/or histologic follow-up, and 92 had clinical follow-up for a period of greater than 2 years. And of these 213 patients, only one turned out to have a malignancy, and that was a patient that had a neuroendocrine MET that was discovered 22 months after the original ultrasound. So the moral from this study is that if you have a typical appearing hemangioma in a patient who's low risk for hepatic malignancy, the yield of doing any type of follow-up is extremely low and is really not justified. Now, what do we mean by high risk for malignancy? So if the patient has a prior history of an extrahepatic malignancy, any current evidence of an extrahepatic malignancy, or chronic liver disease such as hepatitis or cirrhosis, then they're put in that high-risk category. Low-risk category is basically everybody else. And notice that this high-risk category does not include anything about liver function tests, patient demographics, or number or size of lesions. So based on all of this, the recommendation for management of typical hemangiomas or lesions that have the reverse target appearance are, if the patient is at low risk, you do no further follow-up. If the patient is at high risk, then follow-up is indicated, and generally we recommend MRIs. Now, why do we follow up the patients that are high risk? Well, that comes from a study that was conducted in Italy, where they looked at hemangioma-like lesions in patients with cirrhotic livers. And they had a large patient population, almost 2,000 patients with newly diagnosed cirrhosis, and 44 of those patients had hemangioma-appearing lesions. And ultimately, of those 44, 22 were proven to be hemangiomas, but 22 were proven to be hepatocellular cancer. Now also, they looked at about 1,600 patients who on their initial ultrasound scan had no evidence of focal lesions. And of those, 26 developed lesions that looked like hemangiomas on their follow-up sonograms. And of those 26, 22 were hepatocellular cancer, and 4 were dysplastic, potentially malignant or pre-malignant nodules. So the bottom line here is if the patient has chronic liver disease, you clearly need to follow up lesions that have the appearance of a hemangioma, and we also add patients with history of extrahepatic malignancies into that category. So we've talked a little bit about liver metastases also. Now let's focus on that. The liver and the lung are the most common site of distant metastases. METs are most common malignant liver lesion in North America. 50% of patients who die of cancer and have their livers examined at autopsy will have liver metastases. Generally, liver metastases are multiple. That is true in 90%, and they usually involve both lobes of the liver. But realize that 10% of metastases are solitary. Signs and symptoms of liver disease are absent in approximately 50% of patients with liver metastases, and the liver function tests are notoriously unreliable in detecting liver metastases. So imaging plays a critical role, as you all already know. On ultrasound, the appearance of liver metastases is variable. The two most common patterns are the target appearance and the hypoechoic solid appearance. Uncommon appearances occur, though, and are not that infrequent. They can be heterogeneous, hyperechoic, they can be complex cystic, some will contain calcification, and then occasionally you'll have a diffuse infiltrative pattern. But the most common appearance for liver metastases is the targetoid appearance. So let's look at some of these. So these are classic target liver lesions that were all liver metastases in 4 different patients. The 2 up above show a thick hypoechoic rim, and this one shows a thin hypoechoic rim. The thick hypoechoic rim usually correlates with viable proliferative tumor. The thin hypoechoic rim often correlates with compressed liver parenchyma that produces an area of sinusoidal dilatation. Hypoechoic lesions are also fairly common in metastases, and these are 4 different examples of patients that have multiple hypoechoic lesions. Notice in these cases the through transmission behind these solid liver metastases. And that does occur. Just because you see some through transmission does not necessarily imply that a lesion is liquefied. Hyperechoic metastases are uncommon. The tumors that tend to do that most frequently are GI, and particularly colon, neuroendocrine tumors, and ovary. And you can see a neuroendocrine tumor here, a carcinoid, an ovarian tumor here, and then a patient with osteosarcoma. Calcified metastases also occur frequently from GI sources such as the colon and stomach, also from the ovary. And these are 3 different examples of patients with partially calcified metastases from colon cancer. Cystic metastases also occur. They can occur because the lesion is large and outgrows its blood supply. Sarcomas are notoriously cystic, as are squamous cell cancers, and ovarian cancer can also produce complex cystic lesions. And you can see a variety of appearances here, all of which are complex lesions that were metastases. The diffuse heterogeneous pattern also occurs. Here, using a standard curved array transducer, you see that the liver parenchyma looks coarsened. It's hard to necessarily pick out discrete focal lesions. When you're faced with this sort of a situation, you should take a look with a high-resolution linear array and just focus on the near portion of the liver, as we did here. And in this case, you can see that the pattern actually is due to multiple focal hypoechoic lesions. So what do you do when you're faced with what you think may be liver metastases? Well, you confirm the diagnosis first with an ultrasound survey of the abdomen, looking for a primary site or looking for other metastases. And the primary sites that you can diagnose sonographically include, but aren't necessarily limited to, the pancreas, the colon, the stomach, and the kidney. So at the least, you should look at all of those organs. Most of the patients who have what you think will be metastases to the liver will ultimately get a CT of the chest and abdomen, looking for primaries and staging the disease. And then ultimately, many of them will come back for a liver biopsy, or if some other site has been identified that would be easier to reach than the liver, you can certainly biopsy that as well. So here's an example of a patient that presented for an abdominal sonogram, and a large liver mass was detected. Metastatic disease was certainly one of the leading things in the differential diagnosis, and a survey of the abdomen showed a markedly thickened loop of colon in the left lower quadrant due to primary colonic cancer. Now, I mentioned patients coming back for liver biopsies. Ultrasound guidance is extremely successful in making the diagnosis of liver metastases. When we looked at this back in the late 1990s, We collected patients who had lesions that were less than 1.5 centimeters. The mean size in this patient population was 1.3 centimeters, and we had a 96% success rate in making the diagnosis of metastases. And just to give you a reference, a 1.3 centimeter lesion is the size of a M&M. And here's an example of a patient with a history of melanoma, has a 5.8 millimeter lesion in the liver that you can see there that was successfully diagnosed with ultrasound-guided biopsy. Now, one warning to give you is that when you are thinking of metastatic disease to the liver, you also need to include lymphoma in your differential diagnosis. Lymphoma, as you can see here, can be hypoechoic, it can be targetoid, or it can be diffuse and infiltrative. And these three patterns closely simulate metastatic disease. Unlike metastatic disease, lymphoma is almost never echogenic, almost never cystic, and almost never calcifies. Now let's move on to hepatocellular cancer, the third lesion in our list. As you know, hepatocellular cancer is associated with chronic liver disease, primarily cirrhosis and hepatitis B and C, but other diseases that can increase the risk are hemochromatosis and glycogen storage diseases. Most of the time, hepatocellular cancer will either present as a focal or a multifocal mass, but it can also be diffuse and infiltrating. The echogenicity is extremely variable. They are typically hypervascular lesions. You generally will be able to detect that with Doppler, but not always. And venous invasion in unscreened populations is actually quite common, 30 to 60% in the portal vein and 15% in the hepatic veins. But in screened populations, which is what we tend to deal with nowadays, the incidence of venous invasion is much less common. So I'm going to show you a series of hepatocellular cancers. Here is one that is fairly typical appearance. It's a solid hypoechoic lesion. This is one that is a typical target lesion, hyperechoic centrally with a hypoechoic rim. Here's a heterogeneous lesion that has well-defined areas of both increased and decreased echogenicity, which is fairly common for primary liver tumors, hepatomas and adenomas. And here's a lesion that shows a fairly common pattern, a big primary mass, in this case hyperechoic, a small satellite lesion, in this case hypoechoic, and then also direct invasion of the adjacent hepatic vein. If you see this sort of a pattern, hepatocellular cancer should be your primary diagnosis. Rarely, it will appear as multifocal lesions, all of which are small, like we see in this case. It's much more common to have a single dominant lesion and then multiple smaller satellite lesions, but this patient did have hepatocellular cancer. And then it can be more diffusely infiltrating and involve an entire lobe or an entire hemiliver. This is a patient that had a history of cirrhosis, and on sonography you can see that the liver looks heterogeneous, but you don't actually see a discrete mass anyplace within this cirrhotic liver. We did not detect hepatocellular cancer in this patient, but his alpha-theta protein level was extremely high. He went on to have an MRI, and you can see multiple arterial enhancing lesions, and in areas these were confluent and infiltrating. As I mentioned, hepatocellular cancer is a hypervascular lesion. Most of the time you can detect that hypervascularity on Doppler, as we do here. And if you do waveform analysis, the internal vascularity will have an arterial signal. In some cases, the vascularity will be extremely disordered looking. So if you weren't able to appreciate the focal lesion here in the right lobe of the liver, this disordered vascularity should be your clue that there is an underlying neoplasm. Now, I did mention venous invasion. When it does occur, it is generally isoechoic to the liver. It expands the lumen of the vessel, and in most cases, it will have detectable tumor vascularity on Doppler. Sometimes you'll see that the tumor thrombus has direct continuity with the a primary mass, but most of the time you won't be able to appreciate that. And as you can see in these three different patients, the isoechogenicity of the tumor thrombus with the rest of the liver can make it difficult to appreciate. And what you have to do is look for the vein walls, which will appear as hyperechoic structures surrounding the tumor, as we see in all three of these cases. Here's a patient that has a tumor thrombus extending into the main portal vein. On Doppler, you can see there is some detectable blood flow within that thrombus. And waveform analysis of that internal flow shows that it has an arterial signal. And notice that the arterial signal is hepatofugal. In this case, it's below the baseline. It's heading as if it was going out of the liver. And that's very characteristic of hepatocellular cancer. Here's a patient who on MRI had tumor thrombus, or had thrombus in the portal vein, that showed no significant enhancement after contrast administration. They thought that this was tumor thrombus, but hadn't proven it by enhancement patterns, and the patient came on for a ultrasound. You can see the thrombus, involving the entire portal venous system in the right hemiliver. But on Doppler, all we could see was flow around the portal vein thrombus, but not within the thrombus. So in this case, we still weren't sure that this was tumor thrombus, although we suspected it. In cases like this, you can biopsy the tumor thrombus with sonographic guidance, and you can see that's what we did in this case, and the result was consistent with hepatocellular cancer. So what do you do when you think you're dealing with hepatocellular cancer? Well, you confirm the diagnosis initially by doing a survey of the liver sonographically, looking for cirrhosis and looking for vascular invasion. If you see either of those, then your diagnosis is going to be much more firm. You can get alpha-fetoprotein levels. That will help in some cases, although they are notoriously insensitive. Most of these patients will go on to get a contrast-enhanced CT, or nowadays more often an MRI, to look at the enhancement pattern. Contrast-enhanced ultrasound is equally effective in this situation. And then, if necessary, biopsy can be performed. Approximately 50% of the time we can make the diagnosis using fine needle aspiration. The other 50% of the time we have to do core biopsies, at least at our institution. So here's an example of a patient with a nonspecific lesion in the liver. He did have a history of hepatitis. We don't really see the cirrhotic changes on this conventional view, but when you look at high resolution, you see the coarsening and the nodularity of the liver parenchyma, which tells you that this is an abnormal liver parenchyma and makes the diagnosis of hepatocellular cancer much more likely. Now let's move on to focal nodular hyperplasia. This is the second most common solid benign liver lesion after hemangiomas. These lesions are composed of hepatocytes, Kupffer cells, and biliary structures. They often have a central scar that's seen pathologically. They're significantly more common in women than in men, and they're generally asymptomatic. Symptoms such as pain or bleeding are quite uncommon. On sonography, they have an echogenicity very similar to underlying liver, which makes sense since they're composed of all the basic components of liver parenchyma. They may show mass effect on adjacent structures. The central scar that's seen pathologically is rarely seen on non-contrast enhanced sonography, but they have a typical vascular pattern that can be detected, and that's called the spoke wheel pattern, where a vessel will come from the periphery of the lesion in towards the center and then start to branch back out towards the periphery. So these are 4 different patients with focal nodular hyperplasia. The 2 up above, you really don't see a lesion at all on grayscale sonography. And the 2 down below have heterogeneous lesions that are relatively nonspecific. But when Doppler was performed on all of these patients, you can see the typical spoke wheel type pattern on color and power Doppler, which makes the diagnosis much more likely. Pulse Doppler analysis of the internal vascularity will show an arterial signal, similar to what we saw on hepatocellular cancer. Here's a patient with a slightly hypoechoic lesion seen on grayscale sonography and fairly nonspecific vascularity on power Doppler. In a case like this, the spoke wheel pattern sometimes is difficult to appreciate in any single plane of imaging, but if you reconstruct it in 3 dimensions, the spoke wheel pattern will be much more apparent, as it was in this case. So what do you do when you think that you're dealing with focal nodular hyperplasia? Well, at our institution, we confirm the diagnosis with an MRI and look for the typical pattern of enhancement and the central scar on contrast-enhanced scans. Now, not everybody can undergo MRI examinations, and if they can't, then a sulfur colloid scan, which is what we used to do, is also valuable. Approximately 60% of patients will have the lesion either be hot or warm on sulfur colloid scan, and if that's the case, then the diagnosis of focal nodular hyperplasia is essentially confirmed. Now, contrast-enhanced ultrasound is also very effective in showing the typical pattern of enhancement and the central scar, and also often showing a large tortuous feeding vessel. Biopsy may be necessary in some cases, but just realize that this is not an easy diagnosis to make pathologically, and the biopsy may be indeterminate. And then finally, I'd like to talk about hepatic adenomas. These are the least common of all the lesions that we've discussed so far. It's a rare benign tumor that contains hepatocytes, but few, if any, Kupffer cells or bile ducts. Like FNH, it's more common in women than men, and it's associated with birth control pills, anabolic steroids, and glycogen storage disease. These patients are at risk for hemorrhage, so these typically are surgical lesions, and there is a rare but real risk of malignant degeneration. Approximately 20% of hepatic adenomas are solitary and 10% are pedunculated. They have a variable ultrasound appearance that I'll show you in a minute, and generally they're hypervascular, although you don't always detect that hypervascularity with Doppler techniques. Here's a lesion. Solid hypoechoic on grayscale, very nonspecific type lesion, but has quite abundant internal vascularity on power Doppler. Here are 2 different patients with hepatic adenomas. Patient on the left has solid hyperechoic lesions, and patient on the right has a solid heterogeneous lesion with fairly well-defined hypoechoic and hyperechoic lesions. This particular pattern is often seen with primary liver tumors, such as adenomas and hepatocellular cancer. And in this case, hypervascularity was detected on color Doppler. So when you think you're dealing with hepatic adenoma, confirm the diagnosis typically with MRI. Clinical history and symptomatology combined with a suspicious ultrasound appearance and a typical MRI appearance is generally all that we do to make the diagnosis. But sometimes a biopsy will be necessary, and as is in the case with focal nodular hyperplasia, it's not an easy diagnosis to make, and sometimes it's difficult to distinguish an adenoma from a well-differentiated hepatocellular carcinoma. When an adenoma has been diagnosed, they generally will ultimately get surgery because of the potential risk of bleeding. So in summary, sonography, I believe, plays a very valuable role in the evaluation of liver masses. The combination of ultrasound, clinical history, and laboratory values allows for a diagnosis of what the liver mass is in the majority of cases. And if you can't determine what the diagnosis is with sonography, it generally helps in determining what the next best test will be based on the sonographic findings. And then finally, when necessary, ultrasound is an excellent method to use for guiding biopsies of lesions when tissue confirmation is required. Thank you very much.